Is now starting. All attendees are in listen-only mode.
Welcome, everyone. I hope everyone's having a great night tonight. Tonight we're going to talk about which dental devices we use where, and we have a special treat for you. It's myself, Dr. Guy Yatros, and Jason Tierney, the COO of Dental Sleep Solutions, who has years of experience in the dental lab, is going to bring that side of it tonight. How you doing tonight, Jason?
Fantastic. I was going to try to say that I'm Rich Drake with a makeover, but or a make under. But you stole my thunder. Thanks for nothing.
I'm sorry about that. But well, you had your picture up there. If we didn't have the cameras on, we might try to pull it off. But we just decided to do something a little different tonight for various reasons. I think this will be a different slant on something we've done a fair amount of times over the past. As a lot of you know, Jason Tierney worked for a large dental lab for many years. He's been in the dental sleep industry, even helped bring one of the dental devices to market. And so he can certainly give us his opinion on these dental devices, and I think it's going to give us a whole other viewpoint from the lab point of view on which devices we do wear. So glad to have you on here with me tonight, Jason.
Thrilled to be here. Thanks everyone else for being here. We've got about in the neighborhood of 500 registered tonight, so we've got a lot to cover and a lot of people that I think will benefit from tonight's session. And there's a lot of appliances too.
Yeah, we have a lot to go, and you've been doing this about as long as we have, I think, and you've seen a lot of changes in the dental device market. I mean, we still just pulling that jaw forward. That's the goal. That's what we do. But the devices have, just like everything else in life. My first TV isn't as good as the one we have today, and so a lot of the advances just make our devices more comfortable, make them work better, make them easier for the dentist to adjust. And so, Jason, you're the one in charge of putting on a lot of our courses across the country. What's the number one question that the people ask when they're registering?
Well, there are the top two questions are, which device do I use and how do I get paid for it?
Right.
And tonight we're going to focus on one of those. Which dental devices do you use and for which patients? There's probably not one answer that applies all across the board.
Absolutely. And by the way, we're going to try to type in the answers to the questions. We have our member support team. We have a whole team full of dental sleep experts that are going to be typing in some of the questions. So put the questions in the question box. Jason and I promise to get to all the questions and either answer them or make up something before the night's over. We'll address them one way or another. So if we don't get right to them, we'll review them at the end of the night. Keep the questions coming. And I think, Jason, you're the one that came up with this system for how we do this. The best way to select the devices is the system. I think it's the next slide, isn't it?
Yeah,
there it is.
You can do one of two things. You can pin them all up on the dartboard, close your eyes, blindfold, do 3 spins, throw the dart, or you can put one under each cup and mix them up, and ultimately you're going to get in the neighborhood.
Yeah, and to quote my partner and friend, Rich Drake, who does a lot of these webinars with us, he says, you really can't make a bad device. Someone's snoring, they have sleep apnea, they need the airway open. We put some acrylic in there, it holds their jaw forward. The vast majority of the time, it makes a profound difference. So you can't make a bad one, but you can make a better one. And that's what we're going to be talking about tonight is how to make a better device. One thing I think is worth mentioning for those of you who are somewhat new to dental sleep, I know we sometimes sound like preaching, but you don't realize how good you really have it out there. I've been doing this for almost 20 years, and when I first got started doing this, well, first of all, these devices weren't even recommended as a first line of therapy. People were getting their uvulas cut out. People were getting CPAP first. They were referred for all other kinds of things, and dental devices were way down on the list. And the thing that really changed the way we do things and made us decide to develop Dental Sleep Solutions in DS3 was the fact that in 2006, the American Academy of Sleep Medicine looked at a bunch of studies and realized dental devices work. They actually do a very good job of helping the airway. Even the newer parameters, 2015, show that to even be more true. But just to paraphrase what this says, back in 2006, they realized that anybody who has apnea can have, and if they have mild to moderate apnea, they can have a dental device or a CPAP as a first line of therapy. Those were the two choices, not cutting their uvula out. And if someone had severe apnea, they should try the CPAP first because that's possibly more effective. But if they can't wear the CPAP effectively, then the next choice is a dental device. So that's when the parameters changed. And Jason, you've been in the industry since then. I mean, it really has made a big difference in the acceptance of dental device. Wouldn't you say that's true?
I mean, tremendous difference amongst dentists first. The number of dentists adopting dental sleep in their practices, patients, and then also the medical community. It's while it's not always as quick as we'd like to see, it is moving in the right direction. An increasing number of physicians are realizing what these practice parameters say, and some of them actually abiding by them.
Yeah, and you did your part, you in the dental community, whether you're a dentist or a dental team member, getting out, spreading the gospel, spreading the word that, hey, listen, dental devices work. It's the standard of care. CPAPs work. It's the standard of care. And between the two of these really good treatment alternatives, there's really no reason why 85+% of the patients who have apnea are going untreated, which is the real and true numbers, unfortunately. So next time we'll talk a little bit about once you have your patients diagnosed, how do we put these dental devices in the patient's mouth? How do we do impressions? How do we follow up? And how do we not get lost in this whole process? Because we get lost in the process, we get inefficient, and then we kind of get frustrated and maybe don't succeed at dental sleep. I think this really ties it all together.
Yeah, so there will be a link to the next webinar in an email you'll receive after this. And I mean, to your point, Dr. Yatros, the dental sleep medicine isn't particularly particularly difficult, but there is some complexity. There are some steps and processes, and if you don't have a system to manage that patient flow, you miss steps, and you in turn fall through the cracks. And that's really what you guys are going to focus on next time. So keep an eye out for that email and that link. Yeah,
same time on a Tuesday night. Well, we're talking about housekeeping, Jason, and you'll make sure everybody gets their CE.
Yeah, so those of you that have attended these webinars in the past, we typically send you an email the next day with your CE certificate. Kelly on our team, who's responsible for that, decided to take a vacation. I don't know where why she thought that was okay, but she did. She'll be back next week, and she'll email you your CE certificates next week. You will receive them before next Thursday, which is the 18th, I believe. So keep an eye out for those emails. If you don't see it by next Thursday, check your spam folder, check your junk folder. Sometimes they get relegated there. And by the way, as far as that's concerned, you can always update your preferences there so that they don't end up there in the future. Stay on until the end, and we'll be sure that you get that certificate next week.
Fantastic. And so I see some questions coming in. Keep them in the question box. We're going to type those in as we go, but a lot of them we're just going to answer as we get to them and towards the end. As you all know, at Dental Sleep Solutions, if you're new to our webinars, this is all we do. We get up every morning. We have a group of I don't know, a couple dozen team members that come to work every day just to help dentists who want to succeed at dental sleep. Rich Drake's my partner. He's on a lot of these webinars with us. He and I founded Dental Sleep Solutions, and between us, we've done thousands of devices. We do this every day, all day long, and we don't know everything, but we know a lot of what not to do. That's for sure, and we're going to impart as much of that knowledge to you all today as we can.
Yeah, and we'll work to give you a lot of invaluable information tonight. You won't get a commercial, but we do want to just tell you a little bit about what we do. We help dentists all day, every day. Those couple dozen people that Dr. Yatros mentioned, they provide dental practices across the country with the steps you need, the education, the coaching, the software, the support, so you can screen, test, treat, and bill. So if you've got any questions at all about any of those, the things we're talking about tonight, or any other facets of dental sleep, just type them in the box or type consult, and Jody, Mike, or Brandy will circle back with you tomorrow and get you the information you need.
Yeah, I get a lot of positive feedback, Jason, just so you know, and I see people out when I'm lecturing all over the country, and they say, before I ever joined DS3, I would just type in consult, or I would just contact, and we were great at helping, give advice too, because our goal is to help dentists do this, and we're not just out to promote our business. We want you dental offices to get involved in this because it's a high need and it's our passion. So if you really want to learn a lot and in a short period of time, come to one of our hands-on courses. Jason, you've been involved in these for years. You can attest to the quality of information that they obtain at the end of the day.
Yeah, so just really quickly, actually, on that topic, I mean, Dr. Yatros, we met because initially I hired you to do some lecturing at for a dental lab that I was at that did a lot of dental sleep CE and a lot of oral appliances. And the reason that I was so impressed with your lectures, which have continued to evolve over the years, is because the emphasis of your lecture is on the practical roadmap, the actual steps. How many of you dentists on here have attended a course or two or 22 and still not really gotten a lot of traction? And it's not because you lack the desire, it's typically because of the processes, the steps, that roadmap. And that's really what these courses focus on is it's that GPS, it's that process, that path to go through all of these steps. So if you type course now, you'll save $200 with tuition. That includes the dentist, one team member, a custom appliance, a home sleep test, meals, 14 hours of CE, the whole jazz. And it's a career altering course. So type course. Jody, Brandy, Mike will follow up with you tomorrow and get you registered. I'll get off my soapbox. Here's the baton. Run, Dr. Yatros, run.
Well, I don't think you mentioned that it's normally $9.95, so it's only $7.95 with that $200 off, and we only offer that on these courses if you type. On these webinars if you type course. Man, you're going to have me busy. I'm looking at my schedule. I was talking to Maria, who does our travel, and I'm like, my gosh, I'm going to be gone on the world tour here coming up. So look at those dates. We'll put the dates back up again. We're adding more for the fall. I absolutely enjoy doing these courses, and I promise you'll enjoy coming to one if you really want to learn how to do dental sleep in a practical manner. And then we have the advanced course coming up. What's the date on that, Jason? I've got it covered up with my
April 25th through the 27th, and then we've got another one later this year, October 24th through the 26th. And this course is different than any of the other courses that we do. This is an advanced honors course. The content is presented by Dr. Keith Thornton, the inventor of the TAP appliance, which is a device we'll discuss later on today. And Dr. Richard Drake, your partner and co-founder of DS3. We've also got a couple of other guest presenters, but this is really not your DSM 101 course. This is really sort of that next level course where you've treated, I'd say, 3 or 4 dozen patients, you've encountered some obstacles, maybe you're ready to start doing some marketing, you're ready to really kick your physician interactions into overdrive. This is the course for you. So again, if you type course, and actually we haven't discussed this, but I prefer to ask for forgiveness or demand it. But if you type AHC as in Advanced Honors Course, type AHC, and Jody, Brandy, or Mike will contact you tomorrow, get you registered, and we'll knock $500 off the tuition. But that's literally only if you register tomorrow. Please don't contact us a week from now because I may not have a job still then.
Well, I didn't know you're going to. That's fine with me. Yeah. We just want people to come to the courses, and if you type that in, it doesn't obligate you to it, but at least locks that in for you. And then the last thing on this subject, and I see someone typed in a question about Class 3, which devices you use for that. We're going to get to that in just a second, I promise. So it's a great question. There's several devices we might talk about when it comes to that. Last thing is, this is a ways off, but if you want to come, I know a lot of you, I see the names on here of the several hundred people that are on here tonight that came last year. This course, this course, the symposium is really not to be missed, and we will sell out again, certainly on the rooms we did last year. Register early so that you can lock in those rates at the Hilton there in Clearwater.
Yep. See you there.
See you there. Great names. We'll talk. It really is. It's a phenomenal event. So let's talk about treating.
Yep.
We're going to get into the treatment here. We're going to talk about these dental devices. And, you know, I like this slide that my friend, Dr. Alan Moses, gave to me quite a few years ago. And now you all need to pay attention when I hit the button here for the animation, and hopefully it'll work. There it goes. That's what's happening to our patients at night. And all we're wanting to do is prevent that from happening. And so, you know, all these devices do that. So you can't make a bad device, you can make a better one. So just keep in mind, this isn't rocket surgery. Don't be afraid to get started. I think that's one of the key things too. If don't let the device selection slow you down here. Go back. When I first started doing this, Rich was actually my mentor, and he said, just make 5 devices, make 5 taps, make 5 herps, make 5. They didn't have the Pro Somnus at the time. They had. If he would have said, make 5 of those, and I did. Just made them on myself, made them on my friends and family, made them on my patients, and that's where you're going to learn. Now we're going to help take that learning curve down by talking about these, but until you actually do them, you may not understand everything we're talking about. So doing them yourself is the key. So we're going to first start talking about the Medicare-approved devices. So for those of you who want to get involved in this and are doing medical billing and become Medicare providers, and we recommend that you do that. There's a certain way of doing it that's important. Tune into our billing webinars to learn about that. So don't be afraid of Medicare. I actually, here in Florida, I love the Medicare patients. It's actually easier than commercial billing. So don't let that be a deterrent. But if you become a Medicare provider, they have guidelines about which devices are approved and which aren't. And of the devices that are approved, there's only a handful that are approved. Really, the only ones that we utilize on a regular basis and feel that work well are the TAP family of devices. So we have a Dream Tap and a TAP 3 that we can do. You can see those pictured here. We'll talk about both of those. And then we have the herps family of devices, which various labs make. And so we're going to talk about those individually. Anything else you want to add to that, Jason?
Keep rolling. I have plenty to add.
I know you do. So let's talk about the herps first. A friend of mine on that schedule wasn't the Pankey Institute. In between all those courses, I'm going to be at the Pankey Institute during the week. And I teach down there with Steve Carsonson, which is a great course that we're sold out this year. If you want to come, think about it next year. It's every spring. And, man, what a great course. But Steve calls this device the universal device. I mean, I don't. Have I shared that with you, Jason? That's what he calls it?
No, but it entirely makes sense.
It makes sense because I think if you only had one device and you weren't sure, this device, there's very few contraindications. I mean, some patients may like other ones better and different here or there, but the one question that came in I already saw, you can certainly do this on a class 3 patient. This device is almost limitless in its adjustability because there's some tricks about adding shims behind these barrels. So, if you don't know what else to do, get in the family of herps. There's a lot of different labs that make these. We have Respire makes a great one that you see here on the right that has metal. We have other labs like Dynaflex that makes them. I'm real excited about the new Pro Somnus milled herps that's just coming out now that really looks small and thin. I think I have a picture of it coming up in a little while. But there's a lot of different labs that do it. It's been around a long time, and it's certainly one you're going to become familiar with. Jason, are you seeing many people use these double barrels? I don't think we need to spend a lot of time talking about that anymore, do we? Or you're in the lab business, or have been?
Not particularly, no.
Yeah, so the way most of these work is the one on the left. And the way this works is you have a little instrument that you put into this hole. You push it towards that plus that's really hard to see. And as you do that, it rotates this barrel, we call it, and it moves backwards, which moves the jaw forward. Now, most labs have gotten smart and started putting dots, or you can see this one has an arrow, so you know you're going to turn that in that direction. Some labs have 2 of these barrels so that you can actually cinch one up against the other and kind of lock it. I personally would request it without the double barrels. I think it just gets a little more complicated for the patient when you do that. So they come in a lot of different styles, metals, and so forth. One key thing I will mention while I have the barrel picture here, these ball clasps are meant to put elastics on. So the patient, if they're found their mouth's dropping too far open, they're doing too much oral breathing, and we want to emphasize the nasal breathing, having the rubber bands helping encourage the mouth to stay shut can make this device work way better. So whichever lab you use, ask them about putting something into the design so that you can add elastics to the device if needed, and most of the time you do need it.
Yeah, and I think adding those on the front end is the way to go. And if they opt not to use them or they're not necessary for whatever reason, fine, they're there, which is certainly easier than adding them later on.
100% of the time I request them. Yeah.
Yeah, and also, Dr. H, as you mentioned, the double barrels, and your lack of favor for them, and looking at some of the comments here, it looks like most people share that sentiment.
Well, I'm from Kentucky, so it's easy to remember. Single barrel is better than double barrel. Well, that's in bourbon anyway, but
Yeah, I don't know what that means, but keep going.
well, where do we like this? Here's a picture of the Pro Somnus one that's coming, I think coming out in June. They call it the PH. It's I got to see it last week in Las Vegas. It's really small. I'm excited about the launch of it. In general, herps work on most patients, and one of the reasons is that they work is because the mouth is allowed to be open. And so I like to classify devices into kind of two categories. Some of them lock the upper and lower jaw kind of tightly together, don't allow a vertical opening. Others allow more of a free opening. And we think, well, why don't we pick one of those? Is one better than the other? And no, one's not better than the other, but they have different things that make them one more desirable than the other. So if we allow the jaw to open, patients are more comfortable. They can swallow. It's less claustrophobic. Also, if the jaw is allowed to open, the device doesn't have to fit as tightly. Because if something's locked together and you can't open, if there's not retentive, the patient's jaw drops down, what happens? It's stuck to one of the arches. It's stuck to the top or the bottom arch, and it's not effective anymore. So those are the contrasting things. But the negative is when the jaw opens, it can have a negative effect on the airway at some point. So that's why we have to have the ability to add the elastic. So we got to weigh these around here. But in general, this will work on most patients because you can open your mouth. If you have minimal teeth or non-retentive teeth, it'll work because you can make it with very little retention, and it can still stay in the mouth and not pop loose. Mm-hmm. This is great for people who want to grind their teeth side to side. It's good for not only for comfort, but also for durability for that reason. It has almost an infinite amount of adjustability. Most of the time you do that little turn, that's around 1/4 or 1/8 of a millimeter, depending on how far you turn it. You can usually adjust these 5 to 6 millimeters, but there's ways that we can show you to add shims behind the barrels to actually get almost unlimited adjustability. So we'll talk about materials towards the end. You can get this one anything from metal to all acrylic to with liners. It comes in almost every shape and size that you can imagine. Jason, what do you have to add?
How often do you add an anterior deprogrammer to one of these devices?
I'm not usually smart enough to do that to start with, but we certainly add that when we find people that are really clinching.
That doesn't surprise me.
But I would say, maybe 5-10% of the time we end up doing that down the road because we see people are clenching, their jaws are hurting. One of the questions that came in there, Jason, was which is best for TMJ? And I think we don't have time for a whole TMJ lecture here, but I think you know as much about this as I do because I know you've done a lot of research you helped develop the NTI and things like that. If you only hit in the front and you have a deprogrammer, that decreases muscle activity, we believe, in most cases. So you can't clench as hard. So if you have muscle discomfort, that's what you want. But the negative to that is there's nothing hitting in the back, and it loads the joint. So because there's no posterior teeth, it full comes off the front teeth and puts more pressure on the joint. So if you have a joint problem, you don't want that. So you've got to balance these two out. If you want to protect the joint, you want to hit it all the way around or on the back. If you want to decrease muscle function, you hit it in the front. And the good news about this is you can add a deprogrammer to the front. You can add to the back. This is very universal here.
Most of what you said I'd agree with, but my phone is blowing up with texts right now from people arguing the loading the joint. So let's keep moving and talk more about acrylic.
Yes, well, that's true. It's a very controversial subject, and again, we don't have time to debate in 2 hours worth of TMJ. So the other Medicare-approved device that we use on a regular basis in our office is the TAP. There's 2 iterations that are Medicare approved. This is the newest version of the TAP. It's the Dream TAP. Basically, the hook's on the opposite arch. It's on the lower arch versus the upper arch, which the traditional one was. I think I got a picture of it coming up here. There's the traditional one. I'll go back in a second. On this is the TAP 3. But why do we like the TAP? I mean, you've known Keith Thornton longer than I have, Jason. You've been making these before possibly before I was utilizing them. I'll let you give your 2 cents on the
Yeah,
tap here.
you know, the tap's a really nice device. It's again, it is Medicare approved. Uh, it allows, what is it, 5-6 millimeters of adjustment with the standard design. And the Dream Tap, you can swap out hooks where you can get a full 15 millimeters of advancement. So that's nice. Also, the Dream Tap, because the hook is on the lower rather than the upper as it historically was, it allows more tongue space and increased lateral freedom of movement. So any patients that might be bruxers, it does allow them some lateral range of motion, so they don't feel as locked in, which is one of the more frequent concerns about a tap. And then going back to the conversation about the anterior deprogrammer and its standard design, the Dream Tap only has anterior contact. So it does not only protrude the mandible and splint the airway, but it also decreases that temporal contraction and intensity.
Right. And I think one of the couple things that we haven't mentioned, I'm going to go to the next slide here, and you can have the two, the Tap 3 and the Dream Tap, and we use them both in our practice, made by Airway Management Lab. Again, Keith Thornton has been around longer than than some artifacts of the early ages even,
Yeah.
but they've been around a long time. But he's been doing this a long time. And a couple of things I like about the tap from a clinical standpoint. I mean, we talked about the mechanisms of it. One of them is that it's the most researched device out there. And in my opinion, based on just my clinical experience, and then if Rich was on here tonight, he would agree with that. And I've had this conversation with other dentists who've done thousands of devices. If we have one device in our bag of tricks to pull out for someone who has a really severe apnea, we tend to want to pull the tap out. We just feel it can really do a good job of managing severe disease as well as mild to moderate disease. So, but it just seems that we just know it's a standby. It's been there for a long time, and it just works well. The other reason I know it works well for severe disease is if I want to titrate this in the sleep lab, if the patient we're really concerned about them, they're medically fragile, and we want them to actually go into the sleep lab and for us to adjust it there, we can adjust the tap without removing it. And that's really much superior to the other ones. If you want to do the same thing, you got to pop it out of the mouth, wake the patient totally up, turn on the lights, and this works far better for adjusting it during the sleep lab. And last thing, I know Jason has one more thing to comment on, is you can also add the tap PAP pillows to this. There's a way you can actually have a bar that attaches to the front, and then we can put some nasal cannulas so the patient can do combination therapy and have a very secure interface for that. So for severe apnea, it's one of my go-tos because I just have a lot of extra things I can do to make sure it gets me where I need to go. Did you get something else?
Yeah, you know, you mentioned that there's probably been more research. Well, not probably. There's been more research done on the effectiveness of the tap than any other device, and that's true. It has been around a long time. And I just saw a news report the other day that in Greenland, there was an ice melt, and they found a fossil of a tap there from 4,000 years ago.
Keith's been around that long, right?
Yeah.
The negative to the tap is, and I've wore all these devices myself, if I had to rate them, when we did this in our device selector, we did rate these. I think it's one of the less comfortable ones to get used to. It's a little more claustrophobic because it locks you in place. If you can't breathe through your nose, it can make you, like myself, it can make you a little claustrophobic. That being said, most people, if you hand this to them, didn't say, here's your device, most people will get used to it. It is less comfortable by some people's assessments than others, but if they didn't know what to compare it to, they would know no different. So when I see a severe case, as long as I think they'll wear it, I gravitate a lot towards this device. It's been really one of the standbys that we use quite often in our practice.
And there's a couple of questions coming through about which lab dentists should use to get taps from. That's another advantage of the tap is they've got a pretty large network of labs that make the devices, everyone from Glidewell to National Dentex to Space Maintainers and DPS, a bunch of labs that make it. So I'd say check one of those out. Dynaflex, many of them.
Dynaflex. they all, most every lab that's involved in dental sleep to an extent makes this device, both of these iterations of this. All right, so those are the Medicare devices, and just to kind of contrast them, the herps and the tap are a lot different. The herps you can open side to side. The tap's more claustrophobic, but it also is very effective and can be titrated in a sleep lab. So a lot of people say, I wish more devices were Medicare approved, and I agree with that. But I'm just thankful that the two that are Medicare approved are so different. So at least we have a choice. It's rare that we can't treat them with one or the other of those devices. Now, if we don't have the constrictions of Medicare, then we can select, or other insurance constrictions, which typically there aren't, then we can select any FDA cleared device. Here are the other ones we do. Go ahead.
Just real quick, there are a lot of questions coming through. We've got almost 200 people on here tonight, so we can't just open up the audio for everyone. But please keep typing them. We'll try to get to all of them. And I've got a question, a quiz for everybody that's on here real quick. Down in that question box, just type the names of the two Medicare approved devices that we've covered so far. Just want to see who's paying attention.
Good idea. We've never done that before. Fantastic.
On with the EMA, elastic mandibular advancement device.
Yeah, and this is I would say, my comment on this is the most undervalued, or people look at this and go, really? Yeah, really, it works well. We're not trying to impress our patients with a big chunk of hardware in their mouth. We're trying to move their jaw forward with the least amount of material that we can. And this EMA does a very good job. I've had apnea, hypopnea indexes pushing 100 that I've gotten down below 5 with this. So it can be as effective as other devices. And let's just talk about how it kind of works here for a second. Basically, there's an upper and lower tray. Most of the time it's like your suck down material. And then we have different lengths and different rigidities of bands that allow more protrusion and then stiffer on those rubber bands. And I think there's the next picture. There's the different sizes. I think it was 9 different lengths, Jason, of the rubber bands.
So I just want to reiterate there. You're clear, but let me just be extra clear.
Sure.
There are 9 different lengths of straps. They're in 1 millimeter increments. There are 4 different durometers or thicknesses. Each color is a different durometer, and that thickness determines how rigid that strap is.
Right. And so when you look at them here, this is the lengths, and this is the least rigid to the most rigid as you go from left to right. Since we only have an hour, I can tell you the vast majority of the time, my definitive arm is blue. Now, we might use these yellow ones or white ones.
You might want to get that checked.
Yeah. Yeah.
Bad circulation, my friend.
Yeah, very likely. But we use the blue ones because those are the best balance between rigidity and the patient being able to get them on. These clear ones work really well, but man, they can be a real struggle to get on. And then if you use the white ones, they work well, but the patients stretch them out very quickly. So we may start with the white or yellow, just the patient's getting used to it, but then we rapidly move to the blue. And then when we're finished, whatever we end up with this patient, and we've tested them, we're going to go through that fairly quickly at the end here, but how we titrate them. Once we know that they are wearing a 17 blue band and that's the one that they want, then I usually give them about a dozen, maybe more depending on the patient, so 12 of these bands for them to change out every couple of months. They want to switch them out because they can get stretched out. So that's a question that almost always comes out. Do you give this? I don't just hand this patient, here's 30 bands, go figure this out. We're going to show you how we walk through that.
A common question in my past life at the lab was, so how long should these straps last?
Yeah.
What do you say to that?
The answer to all questions, it depends. I mean, it really just depends on the patient and the bruxism, and that's why as we're going through the titration, we see how quick they stretch out. And if they're stretching out a whole lot, then we may switch to the clear, as long as the patient's dexterity will allow them to get those things on there. But I like to see them last 6 to 8 weeks. And what we tell the patient is we give them another, once we determine the definitive length, we have them lay the new one over it every so often and check it, or they can just see when the eye gets all football shaped instead of round, where it goes through the hole there, then they need to go ahead and replace it.
Yeah. Got it.
Football shaped as a clinical term, I guess now.
I think that's common in Colorado with the laws that they've passed there.
Yeah, maybe so.
Yeah.
But what do we like this?
So who do you like this for?
I tell you, I'll talk about who I don't like it for, and I think this is one that does have some contraindications. But if it doesn't have a contraindication, this device works really well. It's small. The patients find it to be comfortable. It's not aesthetically unappealing for someone who's single and worried about having something in their mouth. It's easy to clean because there's no metal nooks and crannies to get in. Where I don't like this device probably the most is durability. I mean, it holds up better than you might ever dream. I mean, I've seen them last as much as almost 10 years on some patients, but it's certainly not as durable as some of the other ones. A key here is to tell the patients not to use these buttons to take it in and out. That's typically what breaks off of those buttons. I think when they pull it in and out those buttons, that's what causes it to some degree.
Those are to maintain the straps, they're not handles.
They're not handles, but it's certainly not as sturdy as these other devices, most of them that we're going to talk about. So durability is one contraindication, and one of the questions that came in was class 3 or real class 2. You have a little less adaptability with this device because you only have so many bands. They can only put those buttons in so many places, and someone who's real class 2 or real class 3. So to start with, I'm probably not going to do this device on them. The other big contraindication is if they're missing some teeth, like especially lower molars here. That's not a good device. Obviously, that's where it's hooking. And other ones, because these are done with the suck down materials, if you've got teeth that are real diverging, real crooked teeth, it's hard to get this to go around it and still get retentive. You finally get it to seat, and now it's falling out. So, I like this on fairly nice occlusion, or not occlusion necessarily, but arch form and alignment of the teeth. With those are really some contraindications where it may be difficult to titrate or utilize this device. But for the most part, this thing works better than you might dream, and the lab bill's typically less than most other ones too.
It is, yeah. It's one of the more affordable devices, and it's difficult to, or maybe impossible to see in that image right there. But the EMA also has those posterior pads. And those are designed to you can't really see it there, but there are two posterior pads that increase the vertical slightly, and that's the intent, the purpose of those. You mentioned that it's not necessarily one of the more durable devices. I would say it's probably contraindicated for bruxers, especially heavy bruxers. If there is some relationship between bruxism and apnea or sleep distorted breathing, giving them those posterior pads to really clench into and grind on is probably not a good thing.
Yeah, and it very well may break too if they're big time bruxers. So, and plus those bands will get stretched out so quickly that you'll have to give them one every week, to keep them from stretching out. So, but try the device out. I'm telling you, it's one of the things that I have people who come up to me and go, I just really didn't think much of the EMA, and then I tried it out, and they're like, wow, I've had some really good success with it.
Yeah, low cost, easy to wear. Again, available at a lot of dental labs across the country. Glidewell, Dynaflex, National Dentex, there's a bunch of them. It's inexpensive. Somebody just said it's inexpensive and easy to wear. Agreed. It's a low profile, low technically involved device.
Right. Yeah, and patients find it to be comfortable. Yep. Which, if you're new to this, having one that the patient goes, "Wow, that feels great." That's what you want to do to start with, So patient compliance is nice to have your first patients really love the device you give them.
So the dorsals, there's three different ones there.
Uh-huh.
What's the scoop of the dorsal?
Well, there's more than 3 different kinds of dorsals, as we'll talk about here. But basically, they go by this dorsal fin. That's what they're named for. So you can see the dorsal. It looks like a dorsal fin on a dolphin or a shark, and they work by having a dorsal fin and then a mechanism to move it forward. Your traditional ones have a block here, as you can see. As you move this little keyway, it moves the block, what pushes the dorsal fin. Some of them, Respire in particular, the fin itself moves. So you adjust the key and then the fin moves, which actually has some advantages in that it stays in the same position relative to the upper arch as the upper arch moves. It stays basically in the same place in the buccal corridor. So they all work. I would say, Jason, this is biased because it's the one I wear. I wear some iteration of the Dorsal most nights. I wear a dental device, and it's just really one of my favorite devices. It allows the mouth to open. But what I like a little bit better than the herps is because there's friction on those wings when it opens, it doesn't really encourage the mouth to open as much. And depending on what angle they make those wings, it can even discourage that even more. The herps almost always wants to drop down. You almost always need to add the elastics. With this particular device, I would always ask for the ability to add elastics because you don't want to send it back to the lab and have to have the hooks put on later and all that. But I find I don't have to utilize the elastics near as often with the Dorsal design.
So we just spent some time this weekend at a meeting in Las Vegas, and Prosomnus was there. They were showing off their new pH Herbst, but yes. I know you've also used the IA and the CA quite a bit in your practice.
Yeah, and I actually, that's the device I've been wearing lately myself, is the IA here. This, is kind of one of the next steps and this, I would consider this a Dorsal design as well. And they have a couple of versions of it. It's a milled device, and Jason, you can talk about the material better than I can. What's the deal on I've got it covered up here. But
it's a polymethyl methacrylate, and it's a milled. Go ahead, say that 3 times fast.
I can't.
Or better yet, spell it once.
I can't do either, so I'll let you handle
But it's a milled material that's it's a more hygienic material, so it absorbs less stain and odor, less bio-gunk, I believe is the term du jour. And because of that milled manufacturing process, the fit is typically more accurate than a hand fabricated device. If your impressions are inaccurate, you might find, it fits accurately, so it's going to fit per that impression, right? I'll come back to the slide in a minute. We just a few months ago got, I think it's this next picture, we have the Carestream 3600 scanner, and we are thrilled with the results we're getting now because even though we've been using the Prosomnus for a while, occasionally we had to adjust them. And with the bite technique we're using and last 24 devices we've put in, we haven't had to touch them. My partner there, you saw, Dr. Elikofer and Elena are utilizing this daily, and I really think the scan technology is really paying for itself in decreased chair time. And so we scan these, and they just drop right in now. The two design differences are these are fixed acrylic wings, and because you have an upper and a lower one, Respire does something similar to that too. It makes this a stronger device too because they're supporting. I don't know if you can see that on the picture very well, but you have kind of a wing going up and a wing going down. But look how thin this thing is. And that's really the way they look when you go in your mouth. It's so small, I really find it to be comfortable. So the way you adjust these. Very small, but it's also very durable.
Very durable because of the dense acrylic, and they have a really good warranty on it as well. And what you do with these is you get these in different arches, and you can dictate where these wings are. So if one wing's a millimeter forward on the top and the other's a 0.5 millimeter on the bottom, then you put those two together and you've advanced it 1.5 millimeters. So what's nice is there's no screws to turn. There's none of this, telling the patient to screw something. There's nothing to get gunked up in these holes. But if you don't like that and you want to have some of that micro adjustment ability, then they make a hybrid here where you can have different trays on the bottom and you can still have your traditional dorsal turn on the top. And the nice thing about this, you'll never run out of advancement. You can always order another tray and get that wing made in a different position so that you don't have to worry about it. You can be very conservative where you start as you walk your patients forward. I've been very happy with this. I have one of my colleagues, a periodontist, who's broken almost everything we've given him, and he's currently wearing one of these and doing real well. So this kind of explains how those uh, are made with the different increments. They have a standard that you can set up the standard with them how you want those done. And they have unlimited arch now available, some of the pricing they have on them. So that's one of the things I didn't like about it before. And now one fee and you can get you don't have to worry about how much this is going to cost me down the road, and they just mill the next one that you need if you need further advance.
So ProSomnus certainly has a lot of advantages in the realm of the Herbst. There are other ones from Somnomed. Dynaflex offers a Herbst with some different materials. National Dentex has their Clear Dream device. So there's a few others out there. ProSomnus is certainly kind of next level dorsal, though.
Yeah, and I've worn the Dynaflex milled device. It's very similar. I like it very much as well. Of the two, the ProSomnus is a little smaller, and they even have a micro version now, too, so that if you've got a really, really small arch patient, they scallop around the teeth even a little bit more just to make it even smaller. My partner showed me a real this arch. I'm like, are you sure it's an adult? They were doing it on the other day. It was such a small arch. It really was the one. So what do I like dorsals in general? As I said, it's really one of my favorite devices. The jaw opens, but not open so much that you have the negative effects of decreased efficacy. It's comfortable. You can do it in most situations, even if the teeth are missing here or there. Even full upper edentulous, there's a technique we could share with you on how to do that. If you can't breathe through your nose as well, this works well. Really, the one thing I would say, it's probably not as durable, depending on which ones you do. You do the metal respirers, you do the ProSomnus, they hold up better, as maybe some of the other designs, such as a TAP or a Herp. So I'm starting to say that less, though, Jason, because the materials have gotten better. It doesn't allow as much sideways movement, and sometimes that is a contraindication as well. But there's very few patients that these are contraindicated on.
What about as far as taking the bite?
Yes.
Is it more technically complex, more important to take an accurate bite since you don't have that play laterally?
Yeah, thanks for bringing that up. I mean, you can tell the question is posed by someone who's had to deal with that in the lab. If we take our bite and we're off to the left or right, and that's not what the patient actually, their midlines aren't off, then the lab's going to have it mounted there, and they're going to make it with the jaw off to the side unless they call you and you get back in for the bite. And I've done that where we didn't notice it, and the patients, now they're off to the side the whole time, and they can't really get back to the center, and then they have jaw problems. So it is clinically imperative, much more so than with a TAP device or even a Herps, that when we protrude them and do the open bite, that their jaws are not to one side or the other, unless that's what they do. If they have a deflection and it's repeatable, and that's what their jaw is doing due to anatomical reasons, then fine, note that for the lab. But don't have a person who normally does this and they bit and they kind of went off to the side. You're going to have some problems with it.
Yeah, absolutely. I just want to stress that one more time. Do all of the dentists on here and all of the lab people on here a favor. If there is a natural deviation in protrusion, note that on the script. Okay. Right. Otherwise, the lab will try to line the midlines up, or if they didn't deflect, or I'm sorry, if they did deflect and it's not natural, it's not a repeatable bite, it's got to be noted on the script. Okay.
Yeah, I tell you, it's another reason I like the scanner, because this just happened the other day. We took the bite and we noticed that it was off, because you've got that big blown up, model now, 3D model. You're looking, I'm like, I had the patient go forward. That's not what they're doing. We repeated the bite. When all that impression material in there for normal bites, it's a little harder to notice if you do that. So it's not impossible, and we have some techniques that can help you. But that's a really good point, especially with the dorsal, more so than the Herps or TAPs. It'll come back to give you some problems.
And I see that it's less indicated for, I think that was supposed to say class 2 or class 3.
It says class 2 or class 2.
Yeah.
I don't know why. Yeah, I mean,
no, seriously, if they're class 2, it's really contraindicated.
Yeah. And
why is that?
That has to do with where the wings are, and maybe with one like the ProSomnus, with more ability to adjust the lower wings, that's probably not as true as much. And your traditional dorsal design with the fixed wing on the lower, the little pad going forward, if they're really class 2 that ends up getting back in here where the coronoid process is, and that comes down to this limited space, and you can get a pinch back there to where you don't have enough room for all that hardware. And real class 3, the wing has to sometimes gets moved too far forward. It's probably less true with the newer designs where we can have, you know, upper and lower wings, and they're smaller to start with. I haven't noticed that, so we probably ought to change that. Possibly class 2 or 3. You know, at least be cautious of it.
Okay. What's
it should say class 2 or 3.
So that's 4. Here's 5. The Panthera.
Yes.
This is not unlike the Prosomnus. This is sort of the next generation of devices.
Yes. This is a 3D printed device that, I mean, it's the whole new technology here. You can order these in any way you want as far as anterior openings, hitting just in the front anterior to programmer, and so forth. But Jason, you being the lab guru, and plus, so I don't mess up the materials, you want to talk about what this is made out of? Because you're more of an expert than I am.
Well, I'm no expert, but it's a polyamide. It's a nylon. For those of you that have used one of these, you know that it's a very flexible, very lightweight material, but it's deceptively it's deceptively durable. It feels very flimsy, and it is very low profile. But it's 3D sintered, 3D printed material that is nearly indestructible. It is a more complex, more involved manufacturing process, and that results in a more durable device with a higher lab fee as well. So if cost is a concern, this may not be the device for that patient. But if durability, ease of wear, ease of use is important, then this is an ideal device.
Yeah, so if someone's going to break something, if I have these huge masseters, if they've already broken a device that we've done in the past, this is the device I'm going to look at seriously at doing. The only reason that you already mentioned the cost. Also, you can't adjust this one as well. I mean, this is an acrylic. So if they're missing teeth or they end up having 2 or 3 crowns down the road, then this, you can't add
you can't add to it.
You can't, and you can't even adjust it as much because it's so thin, because the material is so nice and rigid and durable. They can get this down to less than a millimeter, about a millimeter. Well, if you try to grind out for a new crown, you're through the material before you know what happens. So if patients have poor dentition, and I think they're going to have impending dental work in the next 6 months, year or so, then it's contraindicated. That's probably the biggest reason. And then the cost. Other than that, it's a great device. You have these different arms in different lengths that you just kind of turn and snap. I find it myself to have worn one. It's very, very comfortable. You can make them very thin. And again, we already mentioned it's very durable. So durability, comfort, but not on poor dentition, I'd say is the biggest contraindication, because if you're going to have to redo it, you're going to have to, I mean, if you have any dental work much done at all, you're going to have to redo this device. And that's sometimes disappointing to the patient, especially at a little bit higher dollar amount lab bill.
It's a little disappointing to everyone involved, I think.
Yeah.
But so we just talked about that nylon material. Like you said here, materials matter. There are a few different types that you can use. One is an all hard acrylic. The benefit there is that it's very easy to adjust. You can just use an acrylic burr. Most dentists are familiar with this type of material from bite splints. Another benefit, you can add to it, you can realign it. We just talked a moment ago about how that can't be done with the nylon material. It can be it's a lower profile device, so you've got minimal thickness. And then with these soft liners, but they're typically more comfortable for the patient, right?
Yes,
that's the
one I
pull. Yeah.
Yeah, if I'm really concerned about comfort, this little hard, soft, rubbery material, it goes around undercuts real well too. So if you've got a bunch of diverging teeth, it can flex around those. The negative is they can delaminate, it wears out, it's hard to adjust. And I'm on the belief that you might get a little more single tooth movement because the stuff kind of squishes around these teeth, and we lose some control over the retention of the teeth. If someone just got out of Invisalign, you got to have a lot of conversations with them first of all before you do anything. I probably wouldn't want this material. I'd rather have hard acrylic that's wrapping all the teeth very nicely. But for the patient who's really picky and they're worried about wearing it and they're clenching and they want some of that little cushioning material, we use it quite often for that as well.
You know, a question that I've gotten a few times about an all hard acrylic device is whether or not it can double as a bleach tray.
You know, I suppose you could. But technically, you're supposed to relieve for the bleach. So if it fits really tightly, theoretically, it'd squish the bleach out.
So it doesn't it would ideally have a reservoir.
Correct. Yeah. But that being said, I've given patients bleach and let them use it, and it seems to work fairly well.
Okay.
Depending on how tightly. It's a good question. And then one of our favorite materials is what we call thermacryl. It's the only material I ever use in a tap because I need it to fit real tightly. This material you can heat up. It can get hard after it cools, and when you heat it up, it turns kind of clear, and it's just like you mix the acrylic. And there's a learning curve to this. Airway Management just came out with their newer version of this where it's really a thin layer of this. And once you get used to using it, and with their newer version, it probably is going to be less of a learning curve. I mean, I love this material because this go back to that patient who has a lot of restorative work to do. They can come in and have 3 crowns and an arch. That's no problem. I come in, I heat up the one side of it, I refit it. Or I say Jason knows I'm kidding. Elena or one of my team members would do this for me. They'd refit it, and we're back up in business again. If the device is too loose, have them come back in, heat it up, let it sit in the mouth a little longer as it cools. Then we tease it in and out a few times. Now it's tighter. You know, if it's too tight, then we heat it up and tease it in and out more often as it's cooler. That makes it fit looser. So I love the material. It does add thickness. And probably the biggest negative is this material, if they don't clean it well, it can get all different kinds of funky colors. I mean, it can be anywhere from gray to green, and you can really look disgusting after even 6 months or a year.
Yeah, and one thing for sure, I've seen some things that made me gag.
Yeah.
But for those of you that haven't used this material, just to be clear, this is not a soft liner. When this material cures, it's a very rigid material. So if you've got a patient with short clinical length crowns, a thermacryl or an AccuFit line device could also be indicated for those patients.
Absolutely. And then we already talked about the polyamide. So this is what your Panthera is made out of. So I mean, those are our materials. I think we're just gonna cut down here to the end. I don't think I want to go through the titrations. We had some slides about it. I think I would like to make sure that I get to this one slide here, and then we'll move on so we're finished in time so you can get your CE. Public service announcement. There's my dog. She's laying right here. That's my dog. That's my device. Tell them just keep it away from your pets. This happens. I bet it happened every week in the lab you were in that someone's dog got a hold of it, didn't it, Jason?
Yeah.
Okay. And make the AM aligners. We're talking about. Yeah, you need to somehow recapture the bite. Now, ProSomnus makes a nice hard one you can order from them. Other labs make rubber ones you can order, but we far and away use a material called AM aligner that we get from Airway Metrics or Airway Management rather, or one of the other labs. And if you don't know how to do this, we can send you a link to a video on how to make this. Just type in consultation or something like AM aligner, and someone will contact you and get over this. But basically, it gets the jaw to go back every morning so that we recapture the bite. And I can tell you, after doing this for 20 years, prior to doing this, we had way, way, way more bite changes. And if you'll use these repositioners, you're going to get your jaws to go back much, much more readily. So I'm going to bring up a couple more slides here, and then we'll make sure we get to all the questions here. And if you have more questions about titration, which was the slides that we just didn't have time for, we'll be happy to type consultation in, and we'll go through that with you. We put this slide in because I think this encompasses what dental sleep is. Wouldn't you agree, Jason, that working with all the offices that we do?
Undoubtedly. Can you elaborate?
Yeah, so what do we have over here? We have a picture of someone helping someone else. If you want to help your patients, hang on just a second.
Well, you know what? While you're yelling at the kid,
Yeah.
I mean, really, what we want to convey here, and those of you that have been doing dental sleep for some time, you can attest to this. And to those of you that are new, if you stick with it, you'll find out there is nothing in dentistry that you can do that sort of feeds our sense of altruism more than dental sleep. Your ability to help people. There's also nothing that will give you a greater sense of personal achievement and personal well-being than dental sleep medicine, to know what a positive impact you're making on these people's lives. And then lastly, last and least would be the fact that this can be a real revenue stream. This can be a real production center. Again, I'm stressing that's not the most important thing. I would advocate, or I would state that it's probably in the order that you see here, from left to right. The ability to help people, the ability to feel good about it, and then lastly, the ability to earn a living doing it. So that can be done. There are, I would say, thousands of dentists across the country that are living that dream, if you will. But doing it requires a system. Your first case, your first 2 cases, probably your first dozen cases, you're not going to do it in 45 minutes of doctor time. However, that is the goal. You can provide comprehensive care in 45 minutes of dentist time. If you have a system, if you have processes, repeatable, reproducible processes in place. And that is really what we at DS3 can help you with. It takes some time. It takes some effort on your end, but we do provide you with the education so you know what you're talking about, the coaching so that you can implement that information in a real way, the software to manage those processes, and then lastly, the ongoing support so that you can screen, test, treat, and bill. If that is something you're interested in, you're not obligated to anything. We're not going to try give you a hard sell on anything. Our team will ask you some questions, try to understand where you're at, what your goals are, and what's in the way, and how we might be able to help you bridge the gap. We're not going to try to push anything on you. We're going to, if anything, ask you some questions and just try to understand what your needs are. So type in consult, CONSULT, and Jody, Brandy, or Mike will give you a shout tomorrow and just have a conversation. Our next webinar will really focus on that flow. So Dr. Yatros and Dr. Drake will talk about that step-by-step process to screen, test, treat, and bill. You'll get an email after this that will thank you for attending, and it'll have a link to the next webinar. Additionally, by next Thursday, our colleague, the vacationer, Kelly, will send you an email that'll have your CE certificate as well as a reminder to register for this next webinar. This next webinar, I just want to stress, it may not sound appealing to you. It may not sound sexy to you. It may not sound like what you want. However, after living, breathing, sleeping dental sleep for the last dozen or so years, this next webinar is actually what you need. So register for that webinar. And again, we'd love to talk with you in the interim. So just type consult. Jody, Mike, or Brandy will give you a shout tomorrow, and we'll get that ball rolling. Anything you want to add to that?
No, it'll be a good one. We tend to do some of these again. We haven't done that in quite some time. Our systems have changed. We're always making our systems better. So even if you've heard the treatment steps in the past, we're always trying to do things to improve our systems so the patient experience can be better, as well as your enjoyment and fulfilling your patient's needs. So I think you'll get a lot for it. I don't think you mentioned Dental Sleep Medicine Insider. We're big on giving things away for free. If you want to know anything from how to make a device on an intentionless patient,
how to take a bite, how to use CBCT as it relates to dental sleep, how to add elastics. We've got videos and articles in there about all of those topics, many more, Medicare billing, We've got a pretty esteemed group of contributors from across the dental sleep spectrum. It's free. We send it to your inbox. Just go to dentalsleepinsider.com. You can subscribe in 25 seconds, and we'll get that in your inbox on a quarterly basis.
And you can even go back and look at the past 30 or so editions that we've done once you sign up. So here's the date. Someone asked for those dates again. We're going to get to the rest of the questions here. It looks like a lot of them have been answered. I'm going to scroll through them in just a second to make sure we got all the answers. I think that's how you get a hold of us. I'm going to go leave that up there for a moment, and then I'll go to how you get a hold of us. If you want to know anything, as again, Jason mentioned, type in consult. I've got the question box up here.
Yeah, fortunately, Jody and Mike and Lisa and the rest of the team were able to answer a lot of these questions in real time. So thanks to you all. But just looking through here at some of that maybe we didn't address, recommended appliance for class 3 occlusion. Again, you said the herbs would be your go-to. Some double barrels. Any concerns that you have, Dr. Yatros, with the hooks for the ProSomnus devices?
That's a good question. I can tell you I don't need to use them most of the time on the ProSomnus. The ProSomnus have more of a 90, am I doing this right here? More of a 90-degree upper and lower wing. And because of that, there's a lot of friction there. So I have not had really any trouble with the hooks. If they get in the way, I just cut them off because I'm not using them for the most part with those. So I would encourage you to talk to them about your concerns with it. I've found their lab to be very much dedicated to providing a good experience for their patients and for their dentists, and I think they would be able to help you with whatever issues you're having. I have not had that problem myself. But I'm sure I might in the future.
What about a device like a Dorsal or a Herps that has the bilateral adjustment mechanisms? Patient turns 5 times on the right, and 1, 2, 3. Was I at 3 or 4? I don't remember on the left.
Yeah.
How do we ensure that we're even there?
Yeah, we typically have our patients come back at least for the first check. And that happens. It happens in Florida a lot because we've got some elderly population. When they come in after we've done their subjective titration, we try to check that. I use just a periodontal probe or a caliper to measure them and just look at that to see does it look off. And usually you can tell if it's off by if you use loops and a periodontal probe, you can kind of see that. If you question if it's off, then we count backwards and back it up and see how many they had on each side and get it straightened out. I mean, the prevention is really good instructions for the patient. Really emphasize, look, don't get distracted while you're doing this, okay? You're going to turn it 3 turns, turn it 3 turns, turn it around, do the other side right then. Don't go answer the phone or do something in between because that's where they get confused.
My friend Brandon Waltman's got a question.
Okay.
Brandon, I'm looking at you. No, we'll skip his question. Can you talk a moment? You mentioned that you've got a CareStream unit that you use to scan impressions. Can you talk a little bit about how you scan the bite?
Yeah, that's a great question. I actually had a conversation with Mark Murphy this weekend about that. I actually talked to Rich about it last night. And so there's 2 camps on this. I think the camp I'm in is going to turn out to be the right one. Of course, I wouldn't be in that camp, right? Yeah. But what some people are promoting you do is you take your bite registration fork, Pro Gauge, George Gauge, whatever you're doing, and you just put a little material in the front and a couple little pads in the back and have them bite into it. Or you use the full thing and then you cut some of it away so that you can see the teeth. They even make a bite fork that's got just a couple pads in the back for that. Then you put the bite fork in with the bite registration material, and you marry the 2 together. And when I first started doing this, I'm like, why are we putting that material in there? It just is more junk in there. It's an extra step. And being frugal as I am, that's an extra $10 or something in material and bite fork and all that. Can we try it without it?
Frugal.
And so frugal. Cheap. Same difference. I knew you were going to say it. So what we do is we take the George gauge and we just cut the forks off in the back. Okay, and just bend them and break them off. Mark Murphy says he does the same thing, but doesn't even cut the bite for it. And then you have them bite into the George gauge without the material, and you just tell them to hold still. And then you just marry one side and then the other. And we've done a couple dozen cases and haven't had to touch any of them. That's why I was asking Mark about it this weekend, saying, you've been using scanners or familiar with it more than I am. Will that work? And he goes, I think that's what he's doing it. And I talked to Stacy Lehman about it, and she does it the same way. So I mentioned to Rich, I said, you might want to try this without the bite registration material. I think if someone's got Parkinson's or something, or they're really having a hard time holding position, then I would go back and put the material in. I know I wouldn't throw all my bite registration away, but I think we're having pretty good success by just getting him in position. And then you look at the models, and I noticed, like I said, the other day, the midline was off. I think it's wonderful because now, if we're doing our job right, we're not going to be sending them to the lab with bites that are off, because you have a chance to evaluate that bite. If it doesn't look right for some reason, erase that and go back and do it again.
Yeah, thank you. Looks like anybody else have any other questions? Address that. You know what? I've got a question for you real quick before I give quick public service announcement. Everyone that's on here, you've fulfilled your obligation. So if you've got to jump off of here, again, we'll email your CE certificate to you next week. So if you've got to jump off, feel free to. Otherwise, we don't have any plans this evening, so we're going to sit here and continue to answer questions, and you can keep typing them in. And then also, if you want to attend one of these courses, type course now. We'll get you registered tomorrow. You'll save a couple $100. And if you need any help in your dental sleep practice, you're just getting started and you want to do more of this, you've been doing it and you want to do a lot more, or you're doing a whole lot and you need to streamline your processes, you need to add some efficiency, you need to save some time, just type consult and we'll give you a shout tomorrow. There's a question here, Dr. Yatros. What are the shims that you talked about earlier with the Herbst?
Yeah, so you can get those from the lab. If you have trouble finding them, contact us at Dental Sleep Solutions here, and we'll set you up with a lab. I think we get them from Great Lakes, and they're basically like washers. And if you're nice and talk nice to them, they'll pre-cut them for you. But if not, they're just either come in 1 to, I think, 4 millimeter or 3 millimeter thicknesses, and you cut them, and then you bend them apart, and then you go around the pole, and then you crimp them together. And so whatever thickness that is, that just advanced that device at the same number of turns. If it was 3 millimeters, now you're 3 millimeters more forward. You can back up the barrel, and you're at the same spot. So with those shims, with your traditional Herbst devices, you're never going to run out of advanced ability to advance the device.
There's a question.
So one of the questions.
Oh, go ahead.
About where to start the devices, I see that one.
Yeah.
Here, I'm not going to answer Brandon's question either. I just read it.
Yeah.
But funny. But anyway, as far as where to start in a protrusive position, as far as how far apart we go, the vertical, it depends on the device we're going to do. Most of the time, we're going to start at a 5 or 6 millimeter vertical, unless we're doing a prosomnus, in which case you want to make sure you get the blue bite gauges from them, because they really like it precisely 3 millimeters. So you got to have enough room for your material. Prosomnus can be made at 3 millimeters. How far forward? We're going to go at a forward comfortable position that is somewhere between 40 to 60% of the most retruded to most protruded. And I'm not overly worried about the position as long as I don't go too far forward, because we can typically advance more forward as we go. If we're using a device that has a limitation about how far forward we can go, like a dorsal, a traditional dorsal can only go 5.5 millimeters, I'll get a little more aggressive on how far forward we go. If we're using a prosomnus, I've got unlimited advancement more or less with that. If I'm doing a Herbst, I can put those shims in. I can be more conservative. So somewhere between 40 to 60% of the maximum, the most retruded, the most protruded position is where we start.
So that topic of vertical is there's a little bit of controversy around that. if increasing the vertical further opens the airway. Anecdotally, your experience?
Well, yeah, I mean, there's some people that, say that makes it worse. Some people say it makes it better. And I think they're both right. I think at certain points with certain anatomies, opening the vertical to some extent allows more room for the tongue, allows the patient to have a more open airway. We're talking about at a protrusive position, how wide apart we are. At some point, I believe when you get too wide, it's going to negatively affect the vertical. So I think it's both correct. I think that initially opening the vertical and you use your brain a little bit, you're looking at the people with big tongue sizes, narrow arches. If opening up the vertical makes room for all that a little bit more, then it makes sense. There's one study that I'm familiar with where they made taps with different vertical plates, and they found that somewhere between 7 and 9 millimeters seemed to work, about the same. Maybe the 9 worked a little bit better, but it was kind of questionable. So, like you said, it's controversial. My opinion is open it up enough to make room for the anatomy, and then at some point, if you open up too wide, it's gonna possibly make it worse. And the reason I know that to be true, at least on some cases, is I've had herps that the AHI is still 25, and they're still snoring. And when you add the elastics, what does that do? It decreases the vertical. It goes from not working to the patient not snoring now, and now their AHI is 3. And I've had that happen many times. So I know maintaining that vertical at a lower level on those herpes patients made a difference, at least in those. That answer it there, Jason?
Yeah, thank you. What about you talked a lot about the comfort level of the different devices. Again, anecdotally, just from a comfort and compliance standpoint, which device would you say is your patient's favorite device to wear?
I go back to the Dorsal. I mean, I think the Dorsal, and EMA in some cases, but the Dorsal, I think far and away is just, if you want patient comfort, that's the one I'm going to pull out of my bag of tricks. If I'm going for traditional Dorsal, I'm going to use the flex material, because that's it just gives that little bit of cushion. But at the same time, I might rather have a Dorsal like a Prosomnus or a milled Dorsal like from Dynaflex that's thinner. And if I don't mind the hard acrylic, which most patients don't really know the difference, I can get a much smaller device too. So, I mean, you look at that size, that Prosomnus, it's a really small device. And, what are we trying to do? Move the jaw forward with the least amount of stuff in there. And full credit, the EMA does that fairly well too. Mm-hmm. It's not a lot of stuff in there. And if it's not one of the contraindications we talked about earlier, EMA can be a very comfortable device for many people.
There was a question a little bit ago about which material you prefer for analog impressions, and that I know from our conversations is Kettenbach. And then there's another question here about whether or not the airway metrics system works. And I think it's I'm marrying these two together because Kettenbach actually purchased airway metrics. So can you talk a little bit about your experience with the airway metrics jig system?
I mean, the airway metrics system I think works well for taking the bite, depending on which material. And actually, we've experimented with it a little bit doing the scans. It's a little less stuff in there, although it seems to move a little bit more than the George gauge. The airway metrics are little pieces of acrylic that have different indexes, and you can use it to take the bite. I think for some people that works great. It's small. You have varying verticals, so it's more adaptable for the verticals. So I think that they work great. You still need a George or a Pro gauge because it doesn't give you the range of motion. So once you know the range of motion, then as readily, I mean, you can use the little snore screener they have there and maybe get it from that. But I still feel the need to use a Pro or a George gauge to get the range of motion, and then using those airway metrics. I know Stacy Lehman, who's a DS3 user, and she has a Carestream, and she uses the airway metrics without material to do her bites. And we've tried it. I think it probably works about as well. It's a little less bulky, but the patient can rock back and forth on it just a little bit easier. So I think, it's what works best in your hands. They're not that expensive. Buy a kit, play with it. I think you'll find a use for it in your office. It comes with that snore screener, which basically you have the patient put their, you tell the patient, make a snoring sound through your mouth. All right. And then you have them bite into the snore screener and move their jaw forward. And then they can't make that snoring sound, and boy, it's really has an effect as far as getting them to understand what we're doing. And I know people that use pharyngometry use them quite readily if they're going to be trying to collapse the airways and see what effects it has. Those airway metrics are almost mandatory if you're utilizing that system.
Gotcha. Any other questions here? Anyone? This is your opportunity to ask the expert and me. That's what I'll call my new dental sleep podcast, the expert and me. Anything else?
I don't see anything.
Is there
else.
anybody that's going to the AADSM Mastery course this weekend? Anyone that's going to the ASBA meeting this weekend? Anyone that's going to the Smile Source Exchange this weekend? Yeah. DS3 will be at all three. So if you're going to be at the Smile Source Exchange, be sure to stop and say hi to Dr. Yatros and my colleague, the Colonel Sanders looking Mike Morhard. If you're at the AADSM Mastery course, be sure to stop and say hi to Jody Lee Jacks. Hey, I see you there, Dr. Rauschwerger. And if you're going to be in Scottsdale, my backyard here at the ASBA meeting, I may make a guest appearance, so be sure to stop and give me a high five. Anything else? Any other questions? Not. Anything? Going once. Going. Gone. Enjoy your Tuesday night. Thanks, everybody, for being here. We appreciate you.
Thanks, Jason. Good job, buddy.
All right. Take care. Thank you.